Hello, my name is Sharon Fekrat, and I'm the Vice Chair of Faculty Affairs and the Robert Machemer Distinguished Professor of Ophthalmology at the Duke University School of Medicine. And then I'm also a retina specialist at Duke Health. So when light comes into our eye and to the retina, dopamine is released. And as we age, that dopamine release decreases. And that provides a mechanism for some of the changes that we're seeing in eyes with macular degeneration. Dopamine is produced in the retina in response to light by amacrine cells. And we have many dopamine receptors, not only in the retina, but also the retinal pigment epithelium. So we wanted to study that because there's been some animal evidence and some database evidence that dopaminergic therapies and modulating the signaling of dopamine affects the progression of age-related macular degeneration to geographic atrophy or to wet age-related macular degeneration. So currently, there have been no clinical trials or multi-center trials looking at dopaminergic therapies in AMD. What we have is, in addition to the animal work backing up the science, we have available retrospective database work, some of the work that we've done, and also Jeremy Levine's group at Northwestern. So that's currently what we have. It's not ready at this juncture in order to change the way that we practice. I do want to mention, some of the common dopamine precursors or agonists include levodopa, which is used in individuals with Parkinson's disease. And then there are the dopamine antagonists, including things like haloperidol, metoclopramide, and also an antipsychotic called risperidone. As you know, the treatment landscape for age-related macular degeneration is growing, not only in the wet AMD, anti-VEGF and TKI and gene therapy agents, but also in the geographic atrophy space with complement inhibition. But we're looking earlier and earlier now at ways to prevent progression, so photobiomodulation and intermediate AMD, and we're looking much more closely at the vitamins as well, including AREDS3 coming up. And so dopamine would be something that would be used earlier in the treatment paradigm, such as in early AMD as well as intermediate AMD, because it may decrease the progression to geographic atrophy and may actually increase the progression to wet AMD with dopamine antagonists. So we may pay more attention to the medications that our patients are taking. Well, so it's very unlikely that there would be an industry-sponsored clinical trial regarding these medications that are already available. So it would be something that we would need to do, like going back to clinical trials that have already been completed and doing post-hoc analyses, looking at those individuals and participants in the already completed trials who are currently taking some of these medicines, and then look at the outcomes. I would take a look at the medications, the oral medications that your patients are taking, and sort of pay attention to those that are taking levodopa, and obviously they need to take it for their Parkinson's, and it may decrease the progression to geographic atrophy. But then those patients that are taking dopamine antagonists, which may increase the chance of progression to wet AMD, and sort of just pay attention to that. Are we going to recommend that they stop their antipsychotic, for example? I don't think we're at a stage to make any sort of recommendation like that at this time. But it may be something that we say, oh, that's why this CNV may be harder to treat and may not be responding as well as we would hope they would to existing pharmacotherapy.